USMLE style question on DiGEORGE syndrome. Question: a 2-day-old male newborn is evaluated for cyanosis and difficulty feeding. He was born at 38 weeks gestation to a healthy mother. Pregnancy was complicated by polyhydramnios. On examination, he has low-set ears, micrognathia, a cleft palate, and a harsh systolic murmur heard best at the left upper sternal border. He also has mild hypocalcemic tetany. Laboratory results: calcium, 6.5 milligrams per deciliter, low, parathyroid hormone, decreased. Echocardiography, truncus arteriosus. Which of the following is the most likely cause of this patient's condition? A. Failure of third and fourth pharyngeal pouch development. B. Defective T-cell signaling due to CD40L mutation. C. Failure of B-cell maturation due to a BTK mutation. D. Defective purine metabolism leading to lymphocyte apoptosis. Impaired NADPH oxidase function in phagocytes. Answer: A. Failure of third and fourth pharyngeal pouch development. Explanation: this patient presents with DiGEORGE syndrome, a disorder caused by a 22q11.2 microdeletion, which leads to defective development of the third and fourth pharyngeal pouches. These pouches normally give rise to the thymus and parathyroid glands, and their failure results in absent or hypoplastic thymus, T-cell deficiency, immunodeficiency, recurrent viral and fungal infections, absent or hypoplastic parathyroid glands, hypocalcemia, tetany seizures, congenital heart defects, truncus arteriosus, tetralogy of palate, interrupted aortic arch, facial anomalies, micrognathia, low-set ears, cleft palate. Classic triad for USMLE. 1. Congenital heart defects, truncus arteriosus. 2. Hypocalcemia, tetany, seizures. 3. T-cell deficiency, recurrent infections, absent thymic shadow. Key features of DiGEORGE syndrome. Findings in DiGEORGE syndrome: genetics, 22q11 deletion detect via FISH, embryologic defect, failure of third and fourth pharyngeal pouch development, thymic defect. Absent thymus, T-cells, risk of fungal and viral infections. Hypocalcemia, tetany, seizures. Facial features: micrognathia, low-set ears, cleft cardiac defects. Truncus arteriosus, tetralogy of palate, interrupted aortic arch. T-cell deficiency, risk of candida, viral, fungal infections. CXR finding: absent thymic shadow like diagnosis, FISH for 22q11.2 deletion, calcium supplementation, thymic transplant in severe cases. Why not the other options? B. Defective T-cell signaling due to CD40L mutation. Describes hyper-IgM syndrome, which has high IgM, low IgG, IgA, and recurrent infections, but does not cause hypocalcemia or congenital heart defects. C. Failure of B-cell maturation due to a BTK mutation. Describes X-linked Bruton, a gamma-globulinemia, XLA, which causes recurrent bacterial infections due to B-cell absence, but no hypocalcemia or cardiac defects. D. Defective purine metabolism leading to lymphocyte apoptosis. Describes adenosine deaminase deficiency, DeficID, which causes both B and T-cell deficiency, but does not cause hypocalcemia or facial abnormalities. E. Impaired NADPH oxidase function in phagocytes. Describes chronic granulomatous disease, CGD, which leads to recurrent catalase-positive infections, but does not affect thymic or parathyroid development. Key takeaways for USMLE. DiGEORGE syndrome, 22q11.2 deletion. Defective third and fourth pharyngeal pouches, absent thymus plus absent parathyroids. Triad, congenital heart defects, plus hypocalcemia, T-cell deficiency. Look for recurrent fungal viral infections, tetany, cleft palate, and truncus arteriosus. CXR, absent thymic shadow. Diagnosis, FISH for 22q11.2 deletion. Would you like a question